Good evening, everybody. You're most welcome to our webinar tonight. I'm going to introduce Dr. Mistry soon. Unfortunately, Dr. Mistry's webcam has dropped him at the last minute. These things happen. So you will not be able to see Dr. Mistry, but you will see his PowerPoint presentation. So just one or two arrangements. We will deal with all questions after the talk. In the meantime, if you have a question, please put it in the answer and question part, not in the chat box. And then last thing, I just want to let you know that Dr. Mistry practices in Bryanston on William Nicol Drive in the NHC Medical Center, and also in Honeydew NHC Medical Center on Christian Devet Drive. I will be sending your certificates within the next week. If you haven't received it within the next week, please will you let me know. It is possible that some of you will work from your iPads or maybe your husband or wife's tablets, and we might not recognize it being yours. So that is the reason why you wouldn't get a certificate. So please let me know. Dr. Mistry, thank you very much. We're looking forward to your talk, and I'm ready to hand over to you. Henk and Dr. Mistry. We've had a few gremlins, but we will sort them out. I just want to make sure, Henk and Dr. Mistry, are you all right and ready?
Hello, Hank.
We can hear you. You can carry on.
Hi, is that all right? Can you hear me?
Yes, we can hear you.
Great stuff. And my slide comes up on your side?
Yes, Dr. Mistry.
Great stuff. Good evening, everyone. Thanks for joining us. Apologies for all the technical issues. It's a first time for me, so I'm a Zoom virgin, you can say. Thanks for taking the time from your personal family time to join us for this webinar. And I hope to make it informative and worth your while. And I thought I'd start with this nice cartoon, which just shows us how times have changed and how last year this time we had a nice get-together where we could meet one-on-one and share the evening together, and now we're doing this virtual meeting. But we do need to adapt with the times, and we are grateful for the technology. At least we can still have these academic meetings. So my topic for today is going to be about recurrent corneal erosion syndrome. And I'm going to be giving you a broad overview of the topic, and we're going to give you some important take-home messages. I found that this is quite a common condition that I see in clinical practice. I probably average about 1 or 2 cases a month of recurrent corneal erosion. And I'm quite sure as optometrists you also see your fair share of this condition. And it's a condition which involves the corneal epithelium and basement membrane. And it's characterized by repeated breakdown of the corneal epithelium, And patients are often debilitated by the pain and the visual deficits that it can cause. And it can become quite frustrating because sometimes they might not respond immediately to the treatment, so they often have to come back a few times until we can get it right. Now, in recurrent corneal erosion syndrome, about 2/3 of patients would have had some history of corneal trauma, and about 1/3 of them will have a corneal dystrophy, and mostly it's your epithelial basement membrane dystrophy. And this is a disease of adults, so the highest prevalence usually occurs in those aged between 30 and 40 years. Now, typically a patient will complain of a sudden onset of usually very severe eye pain, usually when waking up in the morning. And I would liken this to the toothache of ophthalmology. Now, if you remember that the cornea is very highly dense in sensory nerve endings. In fact, it's probably the highest compared to any other structure in the body. Then you'll understand that an erosion actually exposes all the raw corneal nerve endings, and that can be a very painful thing. And this pain can last for a few hours to sometimes several days, in severe cases. Now, the pain can be quite severe to even cause optophobia. And this is the fear of opening your eyes. And I'm not talking about how most of us feel in the morning. This is a real condition. And I'll give you two clinical examples of patients I've seen. The one was a gentleman who had epithelial basement membrane dystrophy. And because of the recurrent corneal erosions, he developed sleep disturbance because of the anxiety and the anticipation of waking up each morning with an erosion. And the other lady I had was a lady who developed recurrent corneal erosion because of trauma. And she was treated elsewhere where they did anterior stromal puncture, and it healed very well or responded very well to the treatment. But she was so fearful that she would get another erosion that she decided to wear a bandage contact lens daily for about a year and a half. Eventually, she came to see me because she had very severe dry eye with blepharitis, and she became contact lens intolerant. So it was essential to discontinue the bandage contact lens wear in this patient. And after lots of careful counseling and reassurance, we managed to do that. But these two examples just highlight what an impact this condition can have in a patient's life. The associated symptoms are usually a redness, very sensitive to light, eye with lots of tearing, blurred vision, and also blepharospasm. And usually this is a unilateral condition, although in your dystrophies it can alternate between the eyes. Now, as with your corneal and other external diseases of the eye, the diagnosis is always a visual one. And all you need is a slit lamp and the power of observation. And typically what you would see are areas of loose or irregular hazy epithelium which surrounds an epithelial defect. These are two good examples of what you would see. Now, if you're unable to appreciate the pathology, you can then install some fluorescein eye drops, and the fluorescein will actually stain the epithelial defect. This is called positive staining. And sometimes you'll see negative staining, which is basically areas of loose epithelium which protrudes above your tear film. And this can be an important clue in your epithelial basement membrane dystrophy. In academic centers, they often have access to confocal microscopy, and this can be used instead of a slit lamp because it gives you a 10 times higher magnification and higher resolution for identifying conditions like epithelial basement membrane dystrophy. Now at this point, because we're discussing clinical features and diagnosis, I'd like to share with you two important clinical goals. And the first one is that you should take your blinkers off when you get a patient like this and not zoom into the eye with the pathology, because it's easy to do that and to forget the patient around that eye and the fact that there's a fellow eye to look at. And that fellow eye can often give us important clues of underlying conditions such as dystrophies. And these three pictures that I've put up here gives you good examples of what map dot fingerprint dystrophy looks like, or epithelial basement membrane dystrophy looks like. You can clearly see in the first picture the map-like figures. The second picture has the epithelial microcysts, which we call dots. And in the last picture, you can see the fingerprint lines. The next clinical poll that I'd like to share with you is going to be illustrated by this nostalgic video. And those of you who grew up in the 80s will remember it quite well.
Coffee and Cremora. Also, Cremora. Ah, where did she put it? She knows I like my Cremora. Now she hides it.
Cremora. Tastes so rich and creamy.
Cremora.
You'd expect to find it in the fridge.
Tandy, there's no Cremora in the fridge.
It's not inside, it's on top.
It's not inside, it's on top.
Cremora, top of the coffee creamers.
Okay, so it's important to always look at the lid on top of the eye, because it can also give you important clues as to why this patient presented to you now with a recurrent corneal erosion. And when you look at the lid, you'll often see a blepharitis or meibomian gland dysfunction. Rosacea is also quite common. And then foreign bodies trapped under the lid can also create corneal erosions and can easily be missed if you don't evert that top lid. Incomplete blinking is a subtle sign that you can see in patients with dry eye problems, and lag of thalamus is something which you see in patients with your exposure keratopathy. So remember, always look at the fellow eye and always look under and on top of the lids that cover that eye. Understanding the underlying pathophysiology in this condition will help you to appreciate why we choose certain treatment modalities for recurrent corneal erosion syndrome. Now, going back to your anatomy and histology days, if you look at the left-hand figure, it basically shows you a schematic of what the corneal layers look like. And from the top, you've got your epithelium, which rests on a basement membrane. And the epithelium has three important cell types. The top one is your superficial cells, then a middle layer of wing cells, and at the bottom, you've got your important basal epithelial cells. If you look at the basal epithelial cells, you'll see there are these blue dots at the bottom, which join to the basement epithelium, and those represent hemidesmosomes. And hemidesmosomes are an important part of the anchoring complex that provides a structural link between the intracellular cytoskeleton and the basement membrane. Now, trauma, which includes mechanical trauma to the corneal surface, typically these eyes have had previous abrading injuries, usually years ago, such as a child's finger in the eye, or sharp object like a sharp branch of a tree. And once they've had this trauma, this causes changes in the cell-to-cell and cell-to-matrix interface. The trauma also causes inflammation in the cornea, and that inflammation causes a disruption of the basement membrane, and it weakens the extracellular adhesion network, basically like the roots of a tree get disrupted, and especially at the level of the hemidesmosomes. Trauma also causes an upregulation of certain enzymes, which are called matrix metalloproteinases, and these can also break down scaffolding proteins, which anchor those basal epithelial cells to the basement membrane. In epithelial basement membrane dystrophy, the individuals have dysfunctional hemidesmosomes, and this causes the epithelial cells to adhere quite poorly to that underlying basement membrane, predisposing them to recurrent erosions. Okay, so in order to demonstrate the mechanics behind an erosion of the cornea, I've chosen a very important scientific video that I'd like you to view. Just a warning to sensitive viewers. If you have kids in the room, you might want to send them out. This is a censored video.
It's gonna be good.
Cool.
This is the one right here, right?
Hi, how are you?
So this is your first time getting body waxed?
Yes, it is.
Take off your shirt.
Okay.
Oh, we're gonna need more wax!
I'm staying. This is gonna be good.
And clear all my appointments in the afternoon.
Here we go. Oh, that feels warm. I like your sweater. Does that come in a V-neck?
If she starts doing his pubes, I'm out of here.
You don't look good after this, man.
Thanks, man.
So ready?
Yeah.
1, 2, 3.
Oh, you!
Alrighty then, I think he was going to call her fairy godmother. But basically, what that demonstrates is actually the mechanics around recurrent corneal erosion. What happens at night time, the ocular surface dries out quite a bit, and this creates quite a strong adhesive force between the tarsal conjunctiva and the corneal epithelium. So once the patient wakes up in the morning, that top lid creates a shearing force, which avulses the weak epithelium from the basement membrane. Think of the top lid as that wax strip. Basically, the eyelid is waxing that cornea. There are a number of predisposing factors that will cause a patient to have an erosion, and we've discussed trauma and epithelial basement membrane dystrophy. Just a few points on the basement membrane dystrophy, that it's the most common corneal dystrophy and it affects about 15% of the population. So you definitely will encounter this in clinical practice, and if there's one dystrophy you need to be able to diagnose, this is the one. These patients often have concomitant conditions like dry eye, blepharitis, and meibomian gland dysfunction, which is usually a triad of conditions that coexist. Ocular rosacea is also something that you should look out for, and diabetic patients are also more prone to these conditions. We often have diabetic patients who undergo intravitreal injections, and once they've had a lot of topical anesthetic, they often develop recurrent erosions the next day. Here the mechanism is a little bit different. It's probably combined dry eye neurotrophic cornea. And as luck would have it, I actually had a patient today who presented with epithelial basement membrane dystrophy, and so I've added the color pictures which I took this afternoon. The left image is of the patient's right eye, and if you look very closely at your screen, you'll see the microcyst in the corneal epithelium. A bit lower down in that figure is a geographic map-like figure, and the image on your right side shows the microcyst in the right eye. But remember, it's not inside, it's on top, and if you look at the patient's lid, you'll notice that they have quite a florid posterior blepharitis, and you can see the meibomian gland dysfunction characterized by those concretions within the glands. The differential diagnosis for for recurrent corneal erosion syndrome is quite a long one, but if you do a careful history and examination, it's quite easy to distinguish between these conditions. A hepatic epithelial keratitis can often mimic this, especially when it becomes a geographic ulcer, but always try and test corneal sensation and look for things like keratic precipitates and infiltrates within the stroma. Exposure keratopathy can occur from conditions like proptosis, thyroid eye disease, or those who have had facial nerve problems. Neurotrophic keratitis is from damage to the trigeminal nerve, can also be caused in diabetics, often seen in patients with herpes zoster ophthalmicus. Here, the ulcers often have an oval shape, and the edges tend to have a rolled up appearance. Once again, the corneal sensation will be quite reduced. Conjunctival foreign bodies trapped under the lid. Remember, always look under the top lid. Dry eye, we've discussed infectious keratitis. These patients will have a very painful, angry eye with a staining epithelial defect. Often there's a lot of stromal infiltrate, and they can even have an anterior chamber reaction. Very rare condition is graft versus host disease. It's something that you probably won't see easily in your career. I've seen one when I was at Moorfields, and it's basically patients who've had a bone marrow transplant who then develop an autoimmune or rejection reaction, which then can manifest in lots of different organs, including mucous membranes and on the eye surface. The dystrophies which should be included in your differential would be things like Niesmann's dystrophy and some stromal dystrophies as well, like your lattice dystrophies. Corneal degenerations, Salzmann nodular degeneration, band keratopathy. These can all present with epithelial defects that can mimic a recurrent corneal erosion syndrome. And patients who've had surgery before, like corneal grafts, can also develop these epithelial defects. Now, there's quite a spectrum of treatments available for recurrent corneal erosion, which is basically ranges from your mild, minimally invasive medical treatments through to your more invasive surgical treatments. But in all patients, as ophthalmologists, we'll always use a step-ladder approach, starting with the more conservative measures and building our way up. And in this manner, we can assess each case individually and tailor the treatment. That way we'll minimize any iatrogenic damage and also improve our outcomes. So as an optometrist, as I mentioned before, these patients will often present to you first before coming to the eye specialist. So it's important to make the diagnosis and to initiate first-line treatments, and then to refer all these cases to the ophthalmologist. So the first-line treatment which I would suggest for an optometrist is basically to instill an anesthetic drop first, and this will give the patient a lot of relief from agonizing pain of the condition, and they'll love you for it, and they'll be begging you to give them some of the magic muti to take home. But unfortunately, you can't do that because that would cause more harm. But once you've put the anesthetic drop in, it will also allow you to more easily examine that eye, test visual acuities, and then you can install a gel lubricant drop, apply an eye patch, and refer them to the ophthalmologist. I would probably not recommend putting in a bandage contact lens. Often these patients have blepharitis, and as you know, a bandage contact lens is a foreign body on the eye, and an epithelial defect with a blepharitis will increase the risk of that patient getting a microbial keratitis. Also, the patient is going to need that contact lens removed once they reach the ophthalmologist. So a simple patching of the eye is usually sufficient. Once the patient gets to the ophthalmologist, then we'll start the other first-line medical treatment. And this usually entails a combination of lubricant drops and antibiotic drops. And the aim of your lubricants is to prevent that lid from sticking to the cornea. And it involves a combination of daytime drops and nighttime lubricants. And you can actually advise them to chill their eye drops, and it can give them a lot of pain relief. And usually the lubricants need to be continued for a good few months afterwards, and sometimes indefinitely in patients with very severe dry eye and frequent recurrences. When it comes to topical antibiotics, the choice of it depends on the local availability and which part of the world you come from. But typically we choose your broad spectrum antibiotics like chloramphenicol and tobramycin, one of each, not both. And remember, this is a exposed cornea. The epithelium provides an important protective barrier. And now that there's an erosion, they have a high risk for a microbial keratitis. So to protect the cornea whilst it's healing, we prescribe the topical antibiotic. And just a note on that is that if you're going to install a bandage contact lens, then too it should always be done with topical antibiotics prescribed to protect them against a corneal infection. Once the epithelial defect has healed, then you can introduce hypertonic saline drops or gels, and this creates an osmotic gradient which then promotes adequate epithelial attachment. Second line measures, if the patient has failed the first line measures, you can consider putting in a bandage contact lens with the antibiotic drops prescribed, as we said. Large erosions as well will benefit from using a bandage contact lens. And what it basically does is it provides a protective barrier against the rubbing of the lid, and it also provides a scaffolding which allows that epithelium to then safely migrate across and heal the defect. The bandage contact lens is typically a extended wear lens with a high oxygen permeability and usually a flat base curve. And the bandage contact lens can be left in for up to 8 weeks, but it needs to be changed every 2 weeks just so that the risk of infection is minimal. The other option is a cryopreserved amniotic membrane. So this is basically nature's bandage. And the amniotic membrane again provides a nice biological substrate for that epithelium to heal because it's got important growth factors in it. The example on the right top corner is of the ProCara device, and what it is a scleral ring with the amniotic membrane applied across it. So it makes it much easier to apply to the ocular surface. Normally, amniotic membrane is quite a difficult material to work with. So when you put it on this device, it makes it much easier. It is an expensive choice to use, but in areas where it's available, it's a good option. Punctal occlusion can be considered in your patients with very dry eyes. And what it does is it basically improves the ocular retention of lubricants and the patient's tears. So you would start with something like a temporary punctal plug, and if it helps the patient, you can consider putting in more permanent plugs like your silicone plugs. It's important to remember that if you have active inflammation on the eye surface, like a active blepharitis, you should always avoid putting in the punctal plug, because in these conditions, patients are secreting inflammatory cytokines in the tear film, and retaining that on the eye surface will cause more problems. So always treat the blepharitis first before you decide on putting in punctal plugs, and hence I've put it under secondary minor measures. Autologous serum eye drops also can be used. Basically, it's the patient's own blood which has been spun down, and the serum is extracted and diluted. It contains important growth factors which can facilitate healing and lubrication of the erosion. Another option is your umbilical cord serum drops. You have a commercially available form which is called Opti Serum, made by Next Biosciences. And it's also got important growth factors and neurotrophic factors which can facilitate the healing. These are rather expensive options, but they are helpful in difficult cases. So the combination which actually most patients will get, and which has been proven to be most effective, is basically lubricant eye drops together with oral tetracycline antibiotic or doxycycline and topical corticosteroid drops. And what the tetracyclines and corticosteroids do is they basically reduce the amount of matrix metalloproteinase on the eye surface, and this combination then facilitates more long-term healing of that cornea. Patients can often be placed on this combination for a few months. If the patient has failed your more conservative medical treatments, then you would consider a more invasive surgical option. And the choice of modality depends on the location of the erosion. If the patient has got a peripheral erosion, then it is suitable to consider an anterior stromal puncture. And for all other erosions, you can consider diamond burr polishing, alcohol delamination, or PTK or PRK. And we'll discuss the pros and cons of some of these modalities. Let's start with the anterior stromal puncture. So this is for lesions that are outside the visual axis. And this is done using a bent hypodermic needle. We make little punctures through the corneal epithelium all the way through to the anterior stroma. And what that does is basically microtrauma to induce a fibrocytic response, which then anchors the basal epithelium more strongly. The advantage of this is that it can be done in the rooms, and it's a very safe procedure and quick to do. And as horrific as it may sound, needling the cornea, it's actually a very pleasant thing. Patients don't feel any discomfort with the topical anesthesia. And it's also very successful. Up to 80% of the patients will respond to this modality, and it can be repeated if necessary. Now, one of the downfalls of it is that it does induce scarring in the cornea. Although it's not visible macroscopically, you can see it on the microscope. And if it's done too close to the central cornea, it can induce a lot of glare and blurred vision. If you look at the picture at the bottom, you can see how not to do anterior stromal puncture. Those punctures are actually very close to the central cornea and will then cause visual problems later on. I've used this technique on several patients and actually have had very good outcomes. Usually it's only after you've exhausted all the other measure. Epithelial debridement is basically what the name says, and it just involves removing the epithelium in the central 7 to 8 millimeter bit of the cornea. And you use a blade to do this. And it leaves a rim of healthy epithelium at the periphery, which then can re-epithelialize the defect. And it works fine for active erosions, but it doesn't prevent recurrent corneal erosions. And so you need to combine this with diamond burr polishing. So what this entails is basically using a diamond-coated burr to actually polish the Bowman's layer. So it creates a very smooth surface over which the healthy epithelium can migrate. But the act of polishing actually induces a reactive fibrosis. So that new epithelium which migrates across also adheres very strongly and is less likely to erode. The recovery time for such a procedure is much longer than some of the other modalities, and it carries the risk of causing corneal haze afterwards. But fortunately, the haze is not as severe as, say, with PRK, and it is reversible with time with topical steroids. It usually is quite a very effective modality with very low recurrence of erosions afterwards, and it can be repeated and it can be done in your rooms without the need for theatre. Alcohol delamination is another variant, and what it involves is just putting a very concentrated alcohol solution on the eye surface for about 40 seconds. And what it does is it loosens the epithelial layer all the way through to the basement membrane, allowing you to peel it off like you would do a capsulorhexis. And then you can send this whole specimen through to the laboratory for them to test. And in conditions like epithelial basement membrane dystrophy, electron microscopy can be very helpful to confirm the diagnosis. This procedure causes less haze than with diamond burr polishing, but it does carry the risk of toxicity. So the alcohol solution needs to be contained really well on that cornea that you're treating, and also needs to be rinsed off very thoroughly afterwards. This is a procedure which you have to do in theatre, so it can add to the cost. Lasers. PTK is something that is quite effective as well, and basically we remove the corneal epithelium either just by debriding or using an alcohol solution, and then we apply an excimer laser to remove about 5 to 10 microns of the Bowman's layer. Again, the rationale here is to create a nice smooth surface, allowing that epithelial and basement membrane to regenerate and grow across there more strongly. And it carries with it good short-term results, but we're not so sure about the long-term data. Usually the results are similar to doing a diamond burr polishing, but as we mentioned earlier, these patients can have more haze afterwards. It's also important to know that if you treat too superficially, then it might not be effective, and if you treat too deeply, then you can induce more haze or scarring. If you have patients with refractive errors, then you can basically do a modified PTK, which is a PRK, and you can correct their myopia or astigmatism, and it's basically killing two birds in one. So in conclusion, recurrent corneal erosion is quite a common condition, and as simple as it is to understand, it can be quite challenging to manage. We like to use a stepwise approach and to individualize treatment to get the best outcomes. The data does show that combination treatment usually works best, and this involves topical lubricants, oral tetracycline or doxycycline, and a course of a topical steroid. And in your refractory cases, you can then consider one of the surgical options, and at least there's quite a few to choose from, each with their pros and cons. Again, here you need to tailor it to the individual case scenario. But if you do it correctly, it can be quite rewarding, and these patients can be saved from this debilitating condition. So I hope I've given you some take-home points for this important condition, and I hope that some of the tips that will help you in your clinical practice. I thank you for tuning in, and if you have any questions now, I think you can start posting them.
Okay, doctor, there's one question. Is the tetracycline mainly to address the MG-DFX and blepharitis, or does it contribute to the epiadhesion?
So the tetracycline is used as an immunomodulatory drug, and it's basically to inhibit the production of matrix metalloproteinase. And the matrix metalloproteinase is one of the enzymes which cleaves the fibrils which anchor the basal epithelium together with hemidesmosomes. So that's one of the functions, but yes, it also is to treat the meibomian gland dysfunction that the patient has. So it's basically dual acting.
I don't see any other questions at the moment. I just want to mention, if you think of any questions after the talk or during the week, you're most welcome to email me, and I will send it to Dr. Mistry. I think let's give it 1 or 2 more minutes if anybody still wants to type a question. In the meantime, just a reminder, the YouTube link will be available soon. I will send it with your certificates. And Dr. Mistry will probably send me the PowerPoint presentation. I will see if I can also send that to you. And then I would like to thank Dr. Mistry for the talk, even though we couldn't see your face. We did see your face on invitation. I see there's another question that came through. There's one, how urgent will a referral be for this condition?
So depending on the size of the erosion, for smaller erosions, I could say that they could probably wait till the next day, but for large erosions, I would probably suggest rather have them seen on the day. Remember, the larger your erosion, the more discomfort, but also the higher the risk of that patient picking up a microbial keratitis. So urgency is more to get the patient onto the right treatment and also to prevent infection. So for most patients, same-day referral, and in patients who don't have too much discomfort or with small erosions, even the following day is usually fine.
There's another question. How successful is the autologous serum? I'm not familiar with the pronunciation.
So autologous serum, basically the patient's own serum that's been diluted, is quite successful and probably just as successful as umbilical cord serum. So it's definitely an option. It's definitely something that has a cost to it, can be quite expensive. So you can get away with just using commercially available lubricant drops. It's only in your very resistant cases would you then consider such other options because of the additional growth factors and your neurotrophic factors that come in these biological products. So it is very successful, but you would reserve it for more resistant cases because of the cost issue.
Okay, there's another question. What's the best treatment for acne rosacea with burny eyes?
So in those patients, the tetracyclines and doxycyclines are very successful in helping those patients, but usually they need to be on it for long term, anything from a month up to 3 months, and in some difficult cases we can even continue it much longer. But the mainstay of treatment for acne rosacea is usually oral tetracyclines and doxycycline. You can also consider topical treatments like metronidazole creams around the skin. The other thing which also helps with it is IPL treatment for ocular rosacea. So it's been shown to be quite successful. And in fact, the IPL treatment for dry eye was discovered by accident when they were treating rosacea patients with IPL. So it's a combination of factors, but usually oral and topical creams, and you can consider IPL as well for acne rosacea.
Do you often use a preservative-free antibiotic?
So wherever possible, we'd always try and choose preservative-free drops, even with lubricants. The preference is always to go preservative-free because you want to reduce the surface toxicity. These patients will be using lubricants quite often. The antibiotic is usually until the epithelial defect has healed. So if you can't get a preservative-free antibiotic, then it's not so much an issue. I have a preference for using ointments initially because it just has a long-lasting effect on the eye, and it's quite soothing for the patients to use an ointment initially.
There's another question from Chantalay van der Merwe. During COVID-19 regulations and times, how would Essex be allocated high or low, for example? Or is treatment with meds better for now? And if Essex needed, is it needed, it will be done later? Sorry, I don't know the abbreviation Essex myself.
I think it means surgery. I think
Okay.
I think Chantal means surgery.
Okay.
So yes, in these cases, you don't often have to do surgical treatment. So in the vast majority of them, you can get away with medical treatments, and the combination therapy usually works quite well for them. Remember, there are surgical modalities which you can do in rooms, such as anti-stromal puncture and diamond burr polishing. If there is a patient that needs, for instance, a PTK or an alcohol delamination, we would still do it during COVID times, but we're taking all the precautions with all patients going to theatre.
Is it possible for the epithelium to heal quickly so that the erosion is not visible later in the day?
So the corneal epithelium has the potential to heal quite quickly. So smaller erosions can heal, say, within a maximum of 48 hours. Large erosions can take up to 3 days. And patients who have underlying dystrophies or say are diabetic, they tend to take a bit longer to heal. So I would say that maximum 48 hours usually for an erosion to heal, usually not the same day.
Okay, that's the only questions we have, Dr. Mistry.
I'd like to ask the audience some questions, if they could maybe text and reply. Is that okay, Louise?
I'm sure. Let's do that.
If I could ask the members what or do they see a lot of recurrent corneal erosion syndrome in their practice, and did you find this a relevant topic for you?
Let's just give it some time. Laura, not sure if you're just greeting. Doctor, can you read the answers? Okay, so Laura says...
I've seen Neil's response and Ahmed and Zakir's response, yes.
Okay, Eleonora said, I don't see a lot of RCE. Melanie Scholes enjoyed the talk. Kathy Winter too. Haven't seen many. Let's see what else has come up. Yusuf says it's an interesting topic. One person said no, but very relevant, thanks. Olga said, I don't see much corneal erosions. It was very informative. Chantal, have seen patients with RCES, but mostly infections rather. Chantal Brits, I have a friend, fellow optom with RCE. She does not have MGD, fortunately, so manages well with bandage contact lens.
Okay, can I ask another question? Have you all seen cases of epithelial basement membrane dystrophy? Are you comfortable with recognizing the signs and picking up the condition?
So far not. We do see, Willem Petersen said we do see this from time to time. Sorry, I've got something blocking my view. With the severe dry eye, awakening in the mornings, sclerals often help as well. Now something is blocking my view again, but I'm sure everybody can read it on the question and answer section. Okay, so there's a mix of answers.
Yeah. I think it's one of those conditions that it's easy to miss. And if you don't do a very high magnification slit lamp examination, you can often miss those fine epithelial microcysts and the map figures. So it's also important to remember that it's a continuously evolving condition. So, you know, you could see a patient 1 year with very prominent signs, and they could come to you the year afterwards where they don't have those same signs. And remember, there's a continuous turnover of your epithelial cells. So it's an evolving morphology. But it's an important one to pick up. It's a very common thing. And if you miss it, then it makes it more difficult to treat the condition. So it's nice to recognize it when it's there.
Last question, would scleral lenses be an option as treatment?
So I wouldn't consider it under the treatment options for these patients at this stage. I would say that with the soft contact lenses, the bandage contact lens is probably the first line if you want to use a contact lens, and more for patient comfort, and also because your scleral lens basically vaults over the cornea, so it doesn't really create a scaffolding over which that epithelium can heal. So if you had to choose, I would probably still use a soft bandage contact lens rather than a scleral lens. Remember, scleral lenses also can be quite expensive. And having a lens on such an eye is not something you want to consider long term. So we use it therapeutically for the initial bit, and it needs to be changed also every 2 weeks, because these patients with erosions do have a high risk of a microbial keratitis. So even a scleral lens, always bear in mind that it is a foreign body, and microbes like to adhere to foreign bodies. So the risk of a corneal infection is higher with any type of lens. So, I would consider more of a short-term option and a low-cost option, which is your soft bandage contact lens.
Two more questions. Would you ever have signs without any symptoms?
Usually they always have symptoms. The degree of pain that a patient will experience can be variable. So yeah, not all of them will have the waxing the eyeball type of pain, but you do get some that have very minimal symptoms that will say, I've got this scratchy feeling on my eye. In those cases, you also need to suspect that this patient might be having a reduced corneal sensation. So especially in your diabetic patients, their corneal sensitivity is reduced, and it can affect the degree or severity of symptoms that they have. But I've given you examples of what the typical scenario is. You usually get patients say that I woke up in the early hours of the morning or first thing in the morning with this severe pain in my eye, and it's tearing, I can't open it. And so the symptoms are usually quite prominent. It's quite rare that you should have mild symptoms.
Another question, is 16 magnification high enough to see microcysts?
You can see them, and if they are quite prominent, you could see them at the 16 magnification. But it depends on your slit lamp, and I would suggest always go to the highest power you can to identify them. And they often occur in little crops, so it's not a diffuse thing. So you'd have to use your low magnification to inspect the cornea, look at suspicious areas, and then zoom into the area that you think has got the microcyst. One other trick you can use for identifying changes in epithelial basement membrane dystrophy is retroillumination. This is easier when you've got a dilated pupil, but with retroillumination, it really highlights all the features, especially the fingerprint lines and microcysts.
There's one more. What is the best treatment for lagophthalmos?
Lagophthalmos.
Thank you.
Lagophthalmos, basically an incomplete closure of the eyelid. There too, it depends on the underlying condition. So if you've got a patient with, say, a facial nerve injury, then usually you need to think of tarsorrhaphies or gold weights in the lids. So you probably end up doing more surgery in those patients because the innervation is unlikely to recover. In patients with proptosis, like thyroid eye disease, those patients will benefit from decompression. And then if you have the more common type of nocturnal lagophthalmos, so those people who have the creepy little opening of the eyes when they sleep, there I would suggest a simple nighttime lubricant gel or ointment and a sleep mask. Usually that's sufficient to sort out their problem.
Do you always use or need anesthetic when examining?
It's usually necessary because most of these patients, when they present to you acutely, are in a lot of distress. And they struggle to open the eye for you to examine it. So it is a good tool to have in your rooms. Remember, anesthetics are a diagnostic tool in your rooms. It's not something you would dispense. So in most of these patients, it is necessary. One tip on that topic is that you should always try and test the corneal sensation using a cotton wisp before you put the anesthetic drop in, because sometimes you can miss a reduced corneal sensitivity in these patients. But I find in most patients, you usually have to put in the anesthetic drop. It gives them a lot of relief, and also it then allows you to not have to use a bandage contact lens. So, you know, by the time you can see the ophthalmologist, by simply giving them that initial relief, putting the lubricating drop and applying an eye patch, and you can even suggest they take oral non-steroidals to relieve the pain. They usually are very comfortable. But the initial presentation, it is necessary to put the anesthetic drop in.
Okay, I think that's it for the evening. I think we'll conclude with this. And then, Doctor, thank you very much. A special thank you to Henk and Caitlin for assisting on the technical part. Without them, we might not have had this wonderful talk, Doctor.
Yeah, absolutely. I thank Louise and the technical team for organizing. I do apologize that you couldn't see my handsome face, but it is me behind the screen. It's not a robot. Main thing was that I could show you my slides and the pictures, because that's going to be the take-home message, not my face.
Thank you very much, Doctor. Thank you, everybody. Have a lovely evening. We'll see each other with thanks.
Thanks, everyone, for attending. Enjoy your evening further and stay safe.
Thank you. Bye-bye, everybody.
Bye. Good evening.